Welcome to module number 7, from plane to curved occlusion, curve of Spee. The concept of curve of Spee is the topic of this module. Module 7 of Season 2, Interpretation of a Cephalogram, Webinar Cephalometry in Prosthetic Dentistry and Oral Rehabilitation. Overview Season 2. Ferdinand von Spee, Graf Ferdinand von Spee, described in 1890 this sagittal arrangement of buccal teeth. Here the publication, The Gliding Path of the Mandible Along the Skull, American Dental Association, in 1890. We have different approaches based on occlusal plane to understand the curve. One is the so-called Ortlieb formula described by Jean-Daniel Ortlieb, professor at the University of Marseille. He found a negative correlation of this distance, the perpendicular distance of occlusal plane to the hinge axis, negative correlation to the radius. That means the smaller this distance, the bigger the radius. And we can use this formula to calculate radius curve of Spee in millimeters. Minus 1.42 times dPo plus 134.46, the exact formula in his publication. So in the Ceph we measure the dPo, we put it into the formula, and we get this radius based on this correlation table. If this is a dysknatic patient, we should not use only the formula. It's better to use a correlation table, Ortlieb correlation table, by using two parameters, one vertical parameter similar to the joint, to the dPo concept, using the vertical distance of the xi point to the axis orbital plane. And second, we use the sagittal distance here of the projected incision inferius to the axis orbital plane. So one sagittal parameter and one vertical parameter, while the Ortlieb formula was only based on one vertical parameter. So dysknatic patients, better to use the table. And the table looks like this. We have two measurements, a vertical and a sagittal, the Z and the X. And then we have these two measurements, for example, 40 millimeters here, perpendicular distance of the xi point to axis orbital plane, and let's choose 80 or 79 millimeters, the sagittal position of incision inferius within this coordinate system. And we can read now radius curve of Spee 86. If the measurements are in between two, for example, it's not 79 but 81, so we are between these two, then we have to make an interpolation. So, step 1, to create this curved occlusion, we start with incision inferius, decision-making process, stomion, aesthetics. We have pre-treated the patient with a splint, so the splint height can be used as well. The lower incisor protrusion, the lower incisor inclination, steward angle. We have a lot of parameters to understand the correct position from a vertical and sagittal point of view for the incision inferius. So incision inferius is now established, and we can use occlusal plane inclination to create the second point of occlusal plane, which is the distal cusp of the lower first molar. Just to remind, we can use occlusal plane inclination, relative condylar inclination, this occlusal angle concept, the XI point. If there is a missing first molar, it's a virtual point or mesial marginal ridge of the lower second molar. So we can do this same concept also in case the first molar is absent. So the distal cusp is defined from a sagittal point and from a vertical point based on occlusal plane inclination, and especially vertical also because the incision inferius has this vertical position. The distal cusp of the lower first molar has to be in. It's not on the active cusp of the active arch. It has to be in to avoid a mediotrusive interference. Then we continue to create the active cusp. Here the central cusp of the lower first molar is waxed. Orientation, central fossa of the upper molar. So we have to find the correct relationship already. And very important, occlusal plane is perforated by the central cusp. And from this occlusal plane to the curved occlusion, active cusps are perforating the occlusal plane, and the radius is established or has been calculated by the table or by the TPO concept, by the Ortlieb formula. You have to orient against the upper occlusion, fossa, marginal ridges, considering the dental class, and active cusps have a very similar anterior-posterior distance. So there are geometrical principles of occlusion which already can be seen in this stage of a wax-up. Occlusal plane is perforated by the active cusps, or you can also say active cusps are not elements of the occlusal plane, and active cusps are arranged in a sagittal way in the region of the molars and premolars. Curve of Spee starts with the canine. Front teeth are not part of curve of Spee. And these geometrical principles apply also from a cranial view. There is an harmony in this system already. A harmonic dental arch, no buccal-lingual misalignment. Active cusps have similar anterior-posterior distances, and we are considering aesthetic demands. Easy to establish if the lower active arch is narrow. So when we keep the active arch in the lower narrow, it is easier to create aesthetics in the upper arch. So from occlusal plane, here, after planning the wax-up to the curve of Spee. The principles of the ideas of Jean-Daniel Ortlieb can be described here. We have here a herbivore, a plant eater, and we can see typical elements, morphological elements of this mandible and of this occlusion. First of all, the condyle and the occlusal plane have quite a big distance, a vertical distance. There's a vertical growth. The condyle, compared to carnivore, quite small, fragile. The teeth are arranged in a curve, and this curve passes through the condyle. Compared to an carnivore, as seen here, the vertical development of the ramus mandibulae is not very big. The condyle is strong, oriented more posteriorly, take the load. Teeth are arranged very flat on one plane. So the distance of the occlusal plane in herbivore, which have to chew, is quite big, the TPO, and here the distance is almost zero or zero. The arrangement of these teeth in the carnivore with the zero TPO is on one plane, so no curve of Spee, and here the TPO quite big and this sagittal arrangement of buccal teeth. So how to understand now curve of Spee and the role in a functional occlusion? Let's stop to talk about the curve. Let's make segments of occlusion. Let's understand this sagittal arrangement of occlusion as a sequence of small occlusal planes of different teeth or segments in occlusion. So from curve to occlusal planes in a sequence based on the occlusal elements here. So from a curve to particular segments in occlusion. And now back to the disocclusal angle concept. We have discussed it in the last module. This is a slide from module number 6. The disocclusal angle can be calculated from sagittal condylar inclination minus occlusal plane inclination, gives relative condylar inclination, and using the cusp inclination gives the disocclusal angle. Ideal 8 to 12 degrees. But now a big but. What is the meaning behind? Because we have only one sagittal condylar inclination for the whole system. We have only one occlusal plane for the whole system, but we have different cusp inclinations decreasing from anterior to posterior, from 40 degrees to 15, 12 degrees in the third molar region. And if this is now the consequence, this occlusal angle constantly increases from anterior to posterior. So we cannot say this occlusal angle is 8 to 12 degrees for the whole occlusion based on one occlusal plane. So we have to go one step further. This is a slide from our seminar Minds to Improve Clinical Performance, Gnatological Instruments, which took place in Tallinn in November 22. So we calculate this occlusal angle and we said approximately 10 degrees is our target. Here we have in this table the effect of cusp inclination. If cusp inclination is down to 10 degrees, this occlusal angle is 30 based on these parameters: sagittal condylar inclination 50 degrees, occlusal plane inclination 10 degrees. The same parameters, cusp inclination steep 40 degrees, gives 0. 0 means interference. 30 means insufficiency in occlusion. Now we keep the cusp inclination constant. We are changing occlusal plane inclination. -10 gives an disocclusal angle of 30. +20 gives a disocclusal angle of 10. Again, interference problem versus insufficiency problem. So now the segments of occlusal planes, occlusal segments on speed curve, anterior, canine to first premolar, first to second premolar, first, second, or even third molar. And when we use now these segments of occlusion and we are measuring the inclination of these segments according to the curved arrangement, we may see here we have 0 degrees, we have 10 degrees, which is the overall occlusal plane inclination as well. We have an increased steepness of tooth number 6 with 15 degrees and an increased steepness of tooth number 7 with 25 degrees. And using now these parameters in this table, here the segments, 7, 6, premolars, anterior, sagittal condylar inclination always the same. Occlusal plane inclination in general, here 10 degrees. In the table now inserted the different inclinations of the segments from 0 to 10 to 15 to 25. And then relative condylar inclination changes from 25 here to 50 here, and from anterior to posterior, the inclination of the cusps of occlusal structures is decreasing from 40 degrees to 15 degrees, and the disocclusal angle gets down to 10 in all the segments of occlusion. So this is the impact of curve of Spee, and I hope easy to understand why we call this Spee curve and compensation curve, and why it's better to use segments of occlusion with occlusal plane inclinations in a sequence and use them for the planning and for the treatment strategy. That's it for model number 7, and we will continue with model number 8 in season 2. We will talk about functional dividing plane and the sequential occlusal concept with the dominant canine.